Hi, my name is Clint Gillespie, and today I'll be presenting on non-pharmacological interventions for preventing intensive care unit delirium. So just to start out, I wanted to give some background and just define some of the terms we'll be working with. So delirium is characterized by a change in consciousness and cognition, and this is something that we see a lot with patients in the hospital. So when they first come in, a lot of them will be lucid and they'll be alert and oriented, and then throughout their stay some of them may deteriorate and they may start having hallucinations, confusion, irritability, and change in sleep-wake cycles. And so throughout the research that I looked at as well, most of them had the same criteria for patients that were used in the research, and it was patients over the age of 18, and they had to have a Richmond Agitation Sedation score greater than -4. And that Richmond Agitation Sedation scale basically measures if the patient is conscious and able to respond to questions. So then why does controlling delirium matter? Well, 45 to 87% of all patients in the intensive care unit will experience delirium. And while some people might say, why does it matter as long as they're getting the treatment and the medication that they need to get better? It doesn't matter whether or not they're thinking straight. But statistics have shown that delirious patients have a mortality rate 2.5 higher, 2.5 times higher than those who are lucid. And on top of that, delirious patients also experience lengths of stay in the hospital 1.7 times longer. And longer stays equate to greater chance of either complications or hospital-acquired infections. And so overall, it's better to just control the delirium. And then the third thing I wanted to go over is why not just treat it with drugs? We do have antipsychotic drugs, and many patients do take these drugs, and it can help patients. However, drugs aren't for everyone. Some certain medications will have unwanted side effects. I've seen patients that are taking so many drugs that they have to start taking other drugs to counteract the side effects of the original drugs, and so that's never a good thing. And then some patients have allergies to certain medications and they just can't take them to begin with. And drugs are more expensive than non-pharmacological solutions. So non-pharmacological solutions are more accessible. You don't need a prescription, and pretty much any patient can have it. So when I talk about non-pharmacological solutions, these are the things that I'm talking about. The studies that I looked at, they used any one of these methods, or some of them used multiple combined. So cognitive stimulation is basically administering either puzzles or just simple tests to a patient in order to stimulate their brain. Correction of sensory deficits is giving glasses and or hearing aids to the patient so that they can make sense of their surroundings. Family visitation is having the family visit. Music therapy is playing music for the patient. Improving sleep environment is trying to help the patient get more sleep at night. And that's difficult, especially as nurses, when we have to go in and wake them up to give them medications in the middle of the night or assess them. And then periodic reorientation is where we go in the patient's room and ask them if they know what day of the week it is, where they are, those types of questions. And then if they don't know, we have to reorient them. So this is just an example of a cognitive stimulation test that I mentioned. Well, just a cognitive stimulation example. So if I were a nurse that were administering this type of non-pharmacological intervention, I would give the patient this sheet of paper with all these objects on it, and then I would time them and tell them to circle all the bells as fast as they can. And so if you were a patient and you were circling the bells, it would look like that when you finished. And these types of tests, they think, kind of keep the patient's mind sharp, and so it's considered a type of non-pharmacological intervention. So now to look at the specific studies, the research that I found. There was a couple multi-component studies, and when I say multi-component study, I mean basically a study that implements multiple of those non-pharmacological solutions that I mentioned, so like the cognitive stimulation or the correction of sensory deficits. And so in this study, it took place in Brazil, and nurses implemented 5 different non-pharmacological treatments to see how patients would respond. And the results were actually quite promising. They found that 22% of patients in the control group experienced delirium, whereas only 12.5% in the intervention group experienced delirium. And not only that, but it had a statistical p-value of 0.03. And the only thing about this study is it may have had some shortcomings. It was done at a single center, so just one hospital, and it had limited geographic diversity. So we don't know if this study were implemented internationally around the world, if we could get the same results just because it was smaller scale. And then I just wanted to go over p-value really quick in case anyone hasn't taken statistics or if it's been a while. So in that last slide I mentioned the p-value was 0.03, and the p-value measures the probability of obtaining a certain outcome when there are no difference between treatment groups. So basically, if instead of having an intervention group where they received the treatments and then a control group where they didn't receive anything, if you just had 2 control groups, the p-value measures the probability if you would get the same results. And so with a p-value of 0.03, that means there's a 3% chance that 2 control groups would yield the same exact result as having that intervention group and a control group. And p-values of greater than 0.05 are not statistically significant. So the next study that I looked at took place in the Netherlands, and this was called the Underpin ICU study, and it was another multi-component study. So similar to the one in Brazil, they implemented multiple of these interventions, and as you can see on the right, there's a brochure that I found for this study, and it kind of shows which interventions they implemented. So they had some of the correcting sensory deficits and improving sleep quality. And one thing I did notice about this study is that it said nurses only spent 38 minutes per 8-hour shift implementing these interventions, and so there's not that much research on this topic, so I don't know if 38 minutes is too short or too long, but the results did show that there was only a 1% difference in incidence of delirium between intervention group and control groups, and same with mortality rates. There was only a 1% difference, and the p-value on both of those was quite high. So I think more research may be needed for what the average time spent on interventions should be. Another study I looked at took place in China, and this study measured the difference between sleep biomarkers in lucid patients versus delirious patients. And they did actually find a discrepancy between cortisol and melatonin levels. So they found that delirious patients had much lower levels of melatonin, yet they had much higher levels of cortisol. And so we do know that there's something going on that's causing their bodies to have a discrepancy, but unfortunately the study was more of just a snapshot between the 2 groups. So because the way they did the study is they just took patients that were already delirious and patients that were already lucid and just looked at the sleep biomarkers. So we don't really know what caused the discrepancy, whether the delirium caused it or whether the biomarker levels were like that and then they caused the delirium. So it's kind of like a chicken and egg scenario, and further research would be needed where they maybe pick a group of patients that are all lucid, and then any of them that become delirious, they kind of track the levels into that delirium to see if it caused it or if it was caused by it. The last study I looked at was a retrospective comparative study, and what that means is the researchers basically looked through existing electronic medical records and read through the patient outcomes, and these are records where the patient had already, everything had already happened, and so everything was written down. And the way they divided between the intervention group and the control group was kind of clever. They used COVID-19 as like a natural barrier between the two groups. So in Japan, where this study took place, on February 27th, this particular hospital instituted a no visitors policy due to COVID. And so any records from before February 27th, they could look at these records, and a lot of them, if it had family visitations, they could use these records and look at the outcomes. And then any records from after February 27th, they knew that there would be no visitation, so they could use that as the control group. And then what they found was there was actually a 5% difference in the instance of delirium. So 59% in the intervention group had delirium, whereas 64% in the control group had it. But the p-value was 12.7%, which is higher than the 5% threshold for significance. So that means it was statistically insignificant, and they would probably need either more data or a bigger sample size in order to figure out if it actually works. So in conclusion, delirium is a complex issue, and it can't be attributed to just one factor. Many doctors and researchers speculate that there's multiple factors that go into whether a patient starts becoming delirious, and they think it has to do with sleep deprivation as well as medications that the patient receives, and maybe even the level of pain that the patient's in. Most of the studies that I found in my research were not statistically significant. However, the results did show a slight tilt in favorability towards non-pharmacological interventions, but it was just that either the sample size was too small or there just wasn't enough data to really conclude that it works. Although that one study, the initial study I mentioned from Brazil, did actually show that statistically significant evidence that it did work in that hospital. And so my recommendation is that future research in this topic should be done. There were no adverse patient outcomes from conducting these non-pharmacological interventions, and so since it didn't harm anything, I think that hospitals should continue to do research to see if this type of thing, if non-pharmacological interventions could help. Thank you, and these are my references.